to have a very engaging panel discussion that is going to be quite interactive. And also, we still have some speakers from the team who will be able to come and guide us. Thank you. All right, so it's a slight change in our program. So we'll definitely, just to make sure that we can be able to align with the media briefing that is being prepared for this particular, we'll just change the program slightly. And now we want to get ready to get into the panel discussion. So we have seasoned panelists who are here with us, who are going to guide us on this particular conversation. And we're looking forward to their particular engagement. And even as we do so, even as we get into that panel discussion, ladies and gentlemen, I know we've been seated for a while, and this is going to be quite not intense, but a quite interactive panel discussion. And we have captains of industry who are going to guide us in this particular discussion. But even if as we get ready for that, please, let's just rise one more time. We are in the healthcare business. We need to make sure that our blood is flowing. All right. Make sure that our blood is flowing and in the right motion. Oh my goodness. Great. We now want to get into the panel discussion, ladies and gentlemen. I have the privilege and the honor of inviting the panelists. Our first panelist, ladies and gentlemen, I have the privilege and the honor of calling forward. He is the Chief Executive Officer at Gertrude's Children Hospital, ladies and gentlemen, a man who brings over 16 years of experience in the healthcare sector. Please help me appreciate Dr. Robert Nyarango as he comes forward. It's a pleasure to have you here, Dr. Robert Nyarango. Our next panelist, ladies and gentlemen, he is a physician leader delivering high-value care in Kenya, and he brings over 10 years of experience in the healthcare sector. Ladies and gentlemen, he is hospital manager, Avenue Hospital. Please help me appreciate on stage Dr. Mohammed Said as he comes forward. Our next panelist, ladies and gentlemen, is a transformation mentor and results coach, an organization leader for more than 12 years. The man who wears quite a number of caps. He has been the group managing director at AAR Healthcare Holdings. He was also the managing director, AAR Health Services Limited Uganda, and he is the managing director of Valley Hospital Nakuru. Please help me appreciate on stage Mr. Mark Achola as he comes forward. And ladies and gentlemen, our next panelist, he is the founder and the group managing director of Roy Family Hospital, and he's a man who has a strong foundation in both the medical practice and also healthcare management. Please help me appreciate on stage Dr. Maxwell Okoth as he comes forward. Welcome, Dr. Maxwell. We appreciate you. And ladies and gentlemen, our next panelist to come and join us on stage, he is a man who is well versed when it comes to health economics, pharma economics, health financing, and also health insurance, just to mention a few. He's the vice chairman, Nairobi division at the Kenya Medical Association. Please help me appreciate Mr. Dr. Elijah Matolo as he comes to join me on stage. I think we might need an extra seat. We are for the moderator. And ladies and gentlemen, to moderate this particular conversation, this is a lady who brings well over 14 years of experience in healthcare financing and also management, and has a key focus in insurance industry. She's the founder and chair of Care Manager Association of Kenya. Ladies and gentlemen, please help me appreciate a lady who promotes professionalism, ethical values, and excellence, Effie K. Mbugua, as she comes forward to moderate this particular discussion. Welcome, Effie. We are glad to have you here. And karibu sana, as we make sure that we can be able to bring you on board. Thank you.
Thank you very much. I hope you can hear me. Yes. Good morning, everyone. With us, we have an amazing panel. You've heard the captains of the industry. I'm asking Esther, why only men? And I'm the only lady to sit here with them. So I hope, ladies in the room, you'll have enough questions to ask the men, right? Great. So thank you very much to each and every panelist here. We have an amazing conversation. We have been taking to what SMART is doing to change the industry. What SMART is doing, what I like about SMART is that they are always innovating. And through those innovations, as the healthcare industry, we all benefit. So to start us off, gentlemen, it's a delight to engage with you. I have worked with some, like Mark, in my past industry career at AAR. I have interacted with majority of the team here, so it's great to have you on board. I'll start off with Dr. Robert, and my first question for you is, how has the adoption of new technologies improved the overall patient experience in your organization?
So thank you. Thank you, Effie. So good morning, and I think first of all, thank you for Smart Team for inviting me. And congratulations on the launch of your new product. And I think you lead the pack as far as technology is concerned, integrating providers and payers. So our technology journey started about 20 years ago. And technology, your specific question is about experience of customers. And we look at customers in two phases. The patient that walks in with a sick child, but also there is the customer that Dr. Matolo represents here, who is the insurance company and who is probably the biggest customer to healthcare providers. And so I'll take the question in two parts, the customer who walks in, the patient, and then the payers. So for the customer, I think progressively, it's being noted that patients are not just patients, they're customers. And all the things that worry customers, whether they are buying food, whether they are traveling, whether they're going to a hotel, will worry them as far as service provision is concerned. So they're not just buying clinical care, they're buying service, and they're paying, most of the time, they're paying for the service. And so they'll worry about many things, but I think topmost in the mind is convenience. Yeah, I was in a forum on Tuesday where I was told Gen Zs don't like pens, you know, the pens that you use for writing. And for them, so if they walk into your hospital and you give them a pen to do anything, it's a point of annoyance to start the conversation. So we look at how do we adopt technology progressively to improve convenience. And I think for us, that's the biggest convenience to the patient that walks in. So be it basic things that's eliminating paper, eliminating pens, what I've just mentioned, reducing touch points, reducing the number of entries that they need to make in terms of providing the service, improving the booking process, automated reminder systems. So generally, I think we every single year ask ourselves, what is it that we need to do as far as adopting technology is concerned to improve convenience? And there's a very big array. So convenience is one. Of course, number two is efficiency of the service provision. And in that journey of 20 years, I think we've reduced service time by close to 100%. And every year we ask ourselves, and I'll give you an example of discharge. You know how annoying it is to get discharged from a hospital, right? Yeah, so how do you make sure that the discharge as a hospital is as close as possible to the discharge from a hotel? Because that's a comparison, really. And for us, we started with discharge of 4 hours, down to 2 hours, down to 1.5 hours. And in all that journey, the most constant thing is technology. So two is improving efficiency, both from a time perspective and also from a money perspective. And I think the deployment of technology has helped us reduce the cost of providing care over the 20 years by probably 50%. And this is cost that most of the time will pass on, the savings will pass on to the customer, the client that is coming in. But I think the biggest impact for us in technology as far as customer experience is concerned is what we call continuity of care and the safety of care. Yeah, and I'll give you just one example. So if you're nurses here and doctors, you'll understand what we call a Pew score, pediatric early warning sign. So nurses have to take measurements and have to calculate a Pew score, which then decides what needs to be done. And so we started by first asking ourselves, can you capture the data of the Pew score in an electronic system? Then we went to a point, can the electronic system calculate for your Pew score? Then we went to a point, can the electronic system tell you what to do with the Pew score number? Then we went to a point, can the electronic system alert a doctor who is remote from the hospital that the Pew score is this and you're required to attend to the patient urgently. So in that journey of, and I'm just using that example of the Pew score, is that then the patient experience from a clinical perspective is greatly improved, and it also impacts on outcomes and continuity of care because of adoption of technology. In the last 2 years, we've been able to provide telemedicine, remote consultations to 20,000 patients, which is not just an access issue, but it's a convenience issue, is an efficiency issue, is a cost-saving issue. Coming to insurance providers, I think the biggest challenge between providers, insurance payers, and care providers is there's a very big deficit of trust. Yeah, the care provider thrives at the expense of the insurance company, and that's how it works. And the insurance company wants to also survive and be sustainable. So that lack of trust, I think, over the years, what has helped to improve it, to some extent, is technology. Technology creates transparency, which sometimes is lost in paperwork. So it creates transparency on both ends. This is the service you are giving. This is how you're billing for it. This diagnosis is linked to this treatment, and so on and so on. So I think, to some extent, technology has helped to create transparency, which then goes into improving the trust relation. It may not have, sort out all the trust issues, but I think it will help to create the transparency helps to improve the trust between the payers and the providers. And obviously, there's also a big element of savings and efficiency that comes with adopting technology. Thank you.
Thank you very much, Dr. Robert. Thank you very much, Dr. Robert. That was very comprehensive. We've had the keywords: efficiency, trust. Which other word did we hear? We will come back to the team. Those are very key nuggets, even as we continue to talk about technology and the impact it has. It's good to hear that the discharge time has also reduced because of the use of technology. And listening to you say it's less than 2 hours is really, really amazing, because I think that's a huge pain point for most of the payers in the industry and even for the clients, because at that point, all they need is a discharge out. So thank you very much. I'll come to you, Mark. And for you, I'd like to just ask, how do you address the challenge of keeping up with rapid technology? I think we're in a world where things are moving very fast, and if we are not careful, it will be ahead of us. Maybe you can just walk us through that.
Good morning. And a great question and a difficult one. So I think the first thing I'll say, coming from Valley Hospital, which I'm representing today, background, is that we've recognized technology is here to stay. Okay, I think that's the first thing you have to recognize. And as I give my comments, this is an executive approach, and I think people here at different levels, and some will be with me where I am today, like some of my colleagues on the panel, and then I've got other colleagues who, of course, who would talk to me. And my comments are, take your angle and just know that it affects both of us. Yeah. So technology is here to stay. As Nyarango has spoken, that's other angles of how tech comes in. Now, where I look at it is that as time goes on, more technology is coming out. So to me, the first thing I'd say is that there's risk. Okay. So there's technology overload, if you want my honest opinion. Okay. Because there's so much being thrown at us, whether it's from payers, like Dr. Matoro represents today, whether it's from people who give us other services within our infrastructure, whether it's government, because even government is coming with technology. Like everybody here, I'm sure, is facing SHA. Okay, so it works, it doesn't work, at the end of the day. But still, it comes with technology. So as a provider, you're in the middle. So we are overloaded. I think the other fact to state is that we adapt in the most difficult manner. Yeah, I dare say, in very boldly, providers do not like technology. Because I struggle, I'll be honest. I'm sure my colleagues here have those struggles. And the key word is the adoption. If we measure adoption rates in hospitals or clinics or healthcare facilities, every leader here knows it's a battle, whether you like it or not. And if I was to sit down and have a cup of tea with Nyarango, because I'll relate to his comments, I'll ask him for that particular success they've achieved. there's a lot of struggle behind that journey, for sure. He doesn't even need to tell me. Okay? So let's also recognize it is difficult to adopt in our environment, as much as it's being thrown to us. So how do we keep up? So you need to know where you want to go first, because there are so many things out there. You know, so you can't do everything. And many things are good. Let's also accept there are many good technologies out there. But you have to choose which ones you will work with at what point. Otherwise, you know, the old saying, you do many things, but you're master of none. And that's the danger of technology. So for that thing I tell my teams is, guys, let's be clear where we want to play. The second thing to keep up is you also need to sharpen yourself, because there's a lot going on. And as I've looked at software over the course of time, there's a lot of specialization and subspecialization going on today. That somebody will come with a very narrow area. Like I saw the other day, because, you know, for those of you, you know, infection prevention control is a big conversation in hospitals today. Okay? You know, and it's a practice that is starting to bed into, you know, facilities. You know, again, a difficult conversation. But how do you measure, you know, those practices? And that's where technology comes in, because those will never be big teams. They'll never be big. There'll always be a small team that has to touch the whole facility. So how do they keep track of their items? But you see, at a leadership level, and this is what I say, if that is going to be an area of focus, then you need to be careful and very clear what kind of tech you'll use to support that. Okay? And this is where I talk about value-add systems. Okay? Because Smart may come up and say, okay, Mark, you know, we can solve your problem. Esther will come to me and be like, Esther, this one is very technical. Are you sure? But then some other company will come to me and say, this is the only thing we do. Now, how do I make the choice? Okay? Because I'd prefer to go with the specialist as opposed to the generalist in this case, because it's a very technical area. So one of the things I say is, look for people who understand the subject, but not anybody who can just give you a solution. Because software has evolved. But you need to read a lot to understand, to ask the right questions to your technology provider. That is another way you keep up. The third thing is, and you know, one of the benefits of me being in this meeting is, who do you benchmark against? Who do you benchmark with? So as much as I'm speaking in here, I'm also listening to my colleagues to say, if somebody says something interesting, definitely there's going to be a follow-up conversation. Okay? So who are you benchmarking with to see what they are doing? And is it working or not? That is another way of keeping up, because there is a lot going on. Yeah. So for me, Effie, you know, I'll give it in those three buckets, because, you know, this is a very practical subject, because we want to use technology and not, you know, be students of it, you know, at the end of the day. Thank you.
Thank you very much, Dr. Mark, for summarizing it very well. You can see his coaching hat at work, aside from being the CEO here speaking. So thank you for just breaking it down very clearly, that one, you must have a focus, a vision. Where are you going? Why do you need the solution? And what will it offer you? Two, you must also ask yourself, what are other people doing in the industry that you can benchmark to make a difference? And the third one, as you've noticed, I'll always leave the third to you on the floor to remember. And I don't know, Ian, whether we have awards for anyone who will participate with the panel later, so that we make sure we have good outcomes. Because patient-centered care is all about good outcomes. What are your desired outcomes for your patients? If we don't have good outcomes, if we don't have a focus, as clearly mentioned, then clearly we are going nowhere. You'll keep working without a desired outcome, and that's why patient-centered care is critical. Thank you. So I'll come to Dr. Maxwell. We read a lot of what's happening at RFH, and I know for all the other stakeholders also in the house, and you have been very instrumental in letting us know what you're doing. But I would just like to ask, what strategies have you used to ensure that technology investments align with your organization's missions and goals? Thank you.
Thank you very much. Good morning, everyone. Thank you for inviting me. First, it's an honor to sit here with you this morning. Like Chola said, there's a lot of things coming each and every day. There was HMIS, then HMIS Advanced, that now even has an ERP, then ERP, now we have AI that needs to be integrated with our HMIS. And there's so many things each day. But I always say the first thing you need to consider when you're looking at technological investment is, what is your strategic plan as an institution, and does it align with the vision of the organization? So before you make any investment in technology, you must have a very proper strategic planning and vision alignment. Is it aligning with where the institution needs to go to? If tomorrow your aim is to reach 45 million Kenyans, then you need the most robust telemedicine application. You actually don't need a HMIS, right? So that's where you need to put your money. If your intention is to be the lowest, most affordable organization in this country, then you need to have a technological investment that reduces your costs. And we all know our cost centers are first human resource and pharmaceuticals, which are the biggest key cost centers in hospitals. So what investment will reduce your expenditure in those two centers? So you must break down what is the intention of investing in that technological investment, not because everyone is doing it. You can actually find an organization that is performing much better without a HMIS than an organization that has one. It is ironical, to say the least, but it's possible because they've mastered what they're doing, they've mastered the art of their business, they've mastered their model. So don't just go because everyone is going. But the fact is, where the world is today, you can also not live without technology. That is a fact. But don't just put your money in technology because everyone is putting their money in technology. I've had the experience of changing almost 4 HMIS systems, and I can tell you it is the worst experience you can ever have. The example, and I keep telling people, was at the core of COVID, because nobody knew COVID was coming. And we had put resources to change our HMIS because we thought the one we had was not giving us the background information and data that we needed. Then we invest in this system. We had done a background check, went to where it was working, quote unquote, because vendors will tell you what you want to hear. Then lo and behold, we are at 150% occupancy. Patients are being admitted in the corridors because people need beds with oxygen. And your system cannot even do a basic arithmetic addition. You understand? So here we have invested in a system that was meant to make things better. It made our experience hell on earth. So patients have had a very good clinical experience, but their reviews at the tail end is the worst you can ever get because you can't discharge them timely, you have to counter-check everything. But you're deep in the swimming pool. It's the same thing. I mean, change management is very key. So number one, like I said, is strategic alignment and vision alignment. Number two is data-driven decisions. Don't just go into technological investment because you want to go into technological investment. Does your data advise you that that investment is what you need? The world today tells us that any investment that doesn't have AI will soon be obsolete. Fact. But also, it is not a must. Is Africa ready for AI? Maybe, maybe not. There are parts of Kenya today that you talk AI, and that's not their problem. So yes, I've opened a hospital in Kakuma, for example, and because I want to be stylish and conform with what everyone is doing, I go put AI. Is that what Kakuma needs today? I'm not saying Kakuma is an example, so please, whoever comes from Kakuma, don't hold me. You get, so is that what they need at that particular point? Probably that's not what they need. They just need a basic HMIS system that just gives them patient flow management, right? Come in, we register you, we take you to the doctor, we give you a prescription, we send you to the lab, you pay and go home. That is all they need. So you find somebody wants to get this robust Mercedes-Benz of a system, but that's not what they need. So I always say, what is your minimal viable product in your technological investment before you go into that technology? If you're going to go into telemedicine, we've seen telemedicine applications that were open and they never saw the light of day, despite huge multi-million investments, because they came up with everything lumped up together, and the market is not ready for that. Even before Kenyans just accept that I can be consulted on the phone, it will take time. So what is your minimal viable product of going to market with? Number 3 is stakeholder engagement. Technology is good, but I always say garbage in, garbage out. No matter how much you invest in it, if the data you feed into it is not good enough, it will give you terrible information. And you'll make decisions based on that terrible information. So no matter how much investment you've put in it, you probably will be going at a loss instead of it making you succeed and progress. There are many other factors we consider, but I think top of mind, those 3 would be the most important for today. Thanks.
Okay, thank you very much. Dr. Maxwell, you've had it. What is your strategic plan? It must align to that. And again, it must be aligned to the data that you have. So evidence-based, not just walking in and going for it, because that's the only way you'll achieve the right direction. I'm coming to you, Dr. Mohammed. At Avenue, what is it that you're doing? Or how has technology shaped you to ensure you streamline your operations, and above that, also reduce costs while still ensuring that you maintain high quality care? Maybe if you don't mind, you can just share with us that you feel the public here can listen to. Thank you.
Okay, now this works. Thank you for the invite, and it's an honor to be part of the panel. So it's quite an interesting question, and I think I'll just point out some of the things the panelists have said. So at Avenue, what we've been trying to do is obviously address the key issues that everybody here has said, and I think the top 3 things is patients are looking for patient-centered care is, one is cost efficiency. You want the care at the best possible quality, so that's 1, and 2, best cost possible. No, they don't want any superfluous things added to that care. And the third thing I think Robert mentioned is about convenience. I think that's really key. Hospitals have been known to, you cancel your whole day to go, or you stay 5 hours just to be discharged and things like that. Yeah. So I think convenience is key, and we can't do without technology to address those issues, especially as we increase the number of patients that we are seeing. So the things we've done, I think, from the different angles, I'll start from the cost perspective, streamlining operations in that sense. We've made some changes to our EMR platform, to the electronic health records, and what we have restrictions on the formulary, so that people give what is truly necessary, what is based on evidence, right? Rather than just any medication that the last drug rep had informed you about, right? And so we have to make sure the doctors are adhering to a standard, so that you don't have wild variations in the care the patients are receiving. So we've managed to do that. We've also have order sets that go with that, yeah, for that standard treatment. So the labs, so if the diagnosis, you have a particular diagnosis, then you have the particular order set that goes with it. So we've managed to do those changes on the EMR, and that has allowed us to provide cost-effective care that allows us to work with Dr. Matolo and team to create, interesting models like the fixed fee models and, things that allow us to contain those costs. From a quality perspective, I think I'll mention we have a quality management system that is built in-house, and what this allows us to do is have real-time reporting of incidences at every department, at every level, so every staff has access to it. And the other thing, obviously, as it's being reported digitally, is the information is coming together in real time as well, rather than waiting for the paper to be put together at the end of the month. By that time, you've lost time, and some of the incidences were time sensitive. So I think those interventions have really helped, and also the fact that the convenience of just being able to enter the thing at the nearest computer, or even from your phone, has dramatically increased the number of, by several fold, the number of incidences we're able to receive from the team. And it's by working on these incidences that now you prevent, higher errors, because most of the events that happen at hospitals, like the higher, catastrophic events or sentinel events, they're really a culmination of smaller errors that have accumulated in the system over time, yeah? So when you pick up these latent issues because of the improved reporting, literally, you're improving the quality of that care and keeping patients safe, yeah? The other technology I'll talk about is just something simple. Every hospital has, but just by digitizing it has changed things, is the nurse call system. So we had a nurse call system. So the old one was like a bell. You basically press, it rings, and a nurse responds, switches off the bell and the patient's bedside. But by digitizing it, we're able now to, for example, the patient can have direct communication with the nurse through the nurse call system. So maybe it's just a simple thing. I need this. So instead of the nurse coming, then going back to go find what it was, we're able to solve that. Then the other thing is we're able to track how long it takes for the nurse to respond, and that that accountability, that trust, that improves the time it takes for patient for the nurse, for how long the patient has to wait before they're responded to. And the other thing is you can activate a code blue directly from the nurse call system. So again, it reduces wait, how quickly you can get an emergency team to respond. But for me also the bigger thing is now we're able to collate all the calls that are happening, yeah, from the different units, and this helps you make decisions on the staffing for those units. So that's another thing, just by digitizing a nurse call system can give you. Allow me to talk about two more things as we close on that. So the other thing is just teleradiology. I mean, almost all hospitals again have PACS systems, but for us, we've been able to streamline and reduce cost because we've centralized all our reporting to one or at the hospital in Parklands. So we report almost 200 scans a day because we report for the entire Avenue portfolio, 20 medical centers, 3 hospitals. All the studies are able to come there. So that reduces the cost of reporting, and also we're able to monitor the TAT so that the entire group is getting, how do I put it, a standard in terms of the quality of the reporting. Yeah, you don't have that, like you have disparities between the units, yeah? So it kind of helps us standardize that, and even standardize the TATs, yeah? Then finally, and I think this is probably the most significant project that we've done in digitizing, is ICU, digitizing the ICU workflows. So we got a technology partner who helped us digitize the ICU workflows. So, and I think Robert mentioned the pews. And it's the same kind of thing. In ICU, there are multiple scores, and there are multiple variables that you're monitoring, right? That give you an early warning about the patient deterioration and all. So the system is able to do that automatically and alert the necessary people, right? And it's also able to streamline the workflow, right? So you have like, when the patient is being admitted, all the things that need to be done, there's sort of like a checklist. And you can move to the next page until you complete those things for the patient. So documentation has improved and all that. And the system is able to summarize a lot of this data, put it all together into scoring, into the ICU scores like Apache 2s and all. And you're able to predict what is going to, like the patient's risks and what is going on. And the fact that the entire information is brought together into one dashboard, at one, you have one unified record, You see, the nurses will have their cardex, doctor will need the file, and not all of them can have it at the same time, and there's information lost in between. There are labs that are on paper. So the fact that we have all this in one place and it's all aggregated and there are risk scores running in the background has been really quite significant improvement in the workflows. The nurses now have more time. Yeah, they have the gift of time now to do nursing, not clerical work, right? Because we have a lot of, we also accredited, just like Robert and his hospital, and it comes with a lot of documentation to show that you're complying with the standards you've set. But now all those things are automated out, and the nurse now is able to focus more on the patient, and the collaboration in the team has improved. So I think I'll showcase those ones. I hope that's enough. Yeah? Back to you.
Well, thank you very much, Dr. Mohammed. Wow, wow. Are we hearing that? I also didn't know that, and that's why it's good to be here to learn. The nurse call systems are digitized right now, so it makes them easier for even the nurses working. I'm sure me being a nurse a long time in the bedside, that would be a big plus for me, and I'm sure those who are there are enjoying that. Thank you so much for breaking it down so well, including the quality management system that you already have at the hospital. I think we're here, as Dr. Maxwell said, benchmark. Let's ask ourselves some questions. How can we learn to improve what we are doing? Even just being able to digitize your ICU workflows. I think that's a very big innovative process there. That's a game changer. And we hope to see it on this other side. And I know as I'm about to welcome Dr. Matolo as a pair, he's smiling probably as I saw him nod, you know, oh, this is taking place at Avenue, this is taking place at RFH, this is at Valley Hospital and at Gertrude's. We are all here to learn, so thank you very much. Before I invite Dr. Matolo, we have a Mentimeter that you can actually ask questions, and we'll take the questions after our second round of questions to the panelists, so that we give you ample time also to engage with the panelists. So Dr. Matolo, so sorry, back to the plenary. Feel free to go into Mentimeter, put in your questions there, and we will answer them at the given time. Dr. Matolo, you're very uniquely placed here as the only pair. So I'm sure you're representing the entire pair portfolio. You're the only pair in the house, so I'm sure you have the answers for the entire industry. So as a business leader within the insurance industry, and one that is very innovative, what is your future on technologies do you see having the most impact on patient-centered care, which is our focus today? And how are you preparing for them, either from an Old Mutual perspective, or if you want to talk about it from the industry perspective, we'll be happy to hear what is the future like for you. Thank you.
Thank you. So I think there are quite a number of things that have been mentioned by the other panelists. I think from where we are seated as insurers, we still value most of what is said. We want our members to get a good patient experience. We want the costs to be low, and then also the issue around quality. So in terms of some of the technologies we think are going to make a big difference is, I'll start first with the ones that are centered around the patients. So within the health system, our work is to improve health of our people. So it's improving, maintaining, restoring for those patients who are sick. So the concepts around population health management, how do we keep those who are healthy to remain so? And how do we also make sure that those who are sick get the care that they need efficiently at an affordable cost? So the aspects around population health management, and I'll talk specifically for, let's say, for your children. Yeah, how do you know whether all the children that we have had all the vaccinations they need? Sometimes it's actually very difficult, and saying you want to go to a book that probably you don't even remember where it was, Yeah, that's probably one of the technologies that will really help. Looking at patients with chronic conditions, how do you use the available technologies for patient monitoring to make sure that they're actually controlled? When you look at what we see sometimes, a good number of patients are admitted because they're not well controlled. Yeah, so your pressures are not where they're supposed to be, or your blood sugars are not being well controlled. And there are a lot of technologies available to do that. Just from the basics, yes, you have your blood pressure machine, you have your glucometers, but then you need an accompanying probably application that you're able to record something that can show you trends. And this is something that both happens at the patient level, but even at the hospital level. Because one of the things that I keep on challenging our partners is we have about 15,000 patients with hypertension. And I'd really want one of them to tell me how many of them are controlled. Yeah, because waking up and realizing you got a pre-auth, a patient got a stroke. Then when you start looking at the journey, you realize that, yeah, so there were things that were probably opportunities that were missed out. Maybe it's a patient you needed to escalate their care. Patient wasn't coming in. And there are very many other things that can be used to really optimize that care. And then now aspects around telemedicine, which I've seen Smart saying is going to be part of their new offering, really comes in handy. And it's not a question of whether it is virtual versus physical. It is how do you integrate both in the most efficient way. Yeah, so that you're not asking your patient who you saw 3 months ago and they live, let's say, somewhere in Nyahururu, to come again to Nairobi just to have a 5-minute discussion. Yeah, so that one probably you can have a teleconsult that then now helps you to do that. And just basic things. Can you get refill reminders? Yeah, the number of times patients go into the A&E because their pressures are not okay, but it's because they missed a couple of doses. Yeah, what if there's a technology that can be used to support that? And all these things can now be done on the phone. And then now, finally, now for the patients who, the general population, looking at how do you use the available technologies? I think some of us, or most of us, would probably have a smartwatch. And a smartwatch helps you monitor some things, tracking your steps. Yeah, but what if your insurer would actually reward you for taking the necessary number of steps? Because that's one way of improving your health, reducing the risk of chronic conditions, and reducing also the risk of hospitalizations. I think it's been done in other markets, and I'm happy to say that at Old Mutual you're actually bringing something to the market, a behavioral health app that is going to be encouraging our members. You'll be rewarded for looking after your physical health, your mental health, and all these things are available online. And it's been shown in markets where it's worked that patients who engage with these are generally healthier, they have a higher life expectancy, they have lower risk of chronic conditions, which is really what the insurer is actually looking at. Thank you.
Thank you very much, Dr. Matolo, for sharing with us what technologies you see will have a big impact, even in terms of us being able to understand how to improve our patient-centered care, and what you're doing to prepare to support that in the medical business. So when we look at the apps that are available today in the market, Dr. Matolo has brought it out very clearly, the behavioral health apps. He may not tell us all the trade secrets, but we already know what they have in the market. You can go in also to Old Mutual pages and just see what's happening generally. As we ask ourselves the question today, we've come to discuss on how to improve our patient-centered care approaches. So thanks a lot, Daktari. And I'd like to shift gears back to Dr. Robert, CEO Gertrude's Hospital. As you shared earlier, we would like to just hear out of experience, as a data-driven healthcare institution, how does your hospital utilize data analytics for patient-centered care?
Okay, so two things first. I think I want to agree with one of the panelists who says that if you get into data use, there's a need to have a data strategy, and I think most people skip that part when they start using data. So it's critical to, and then probably that's where we started. To have a data strategy, you need to ask ourselves, why do you need data? What kind of data? How are you going to analyze it? Are you going to deploy it, communicate it, apply? And most critically, how do you convert data into useful information for decision making? So having a strategy is critical. Number two is also having a phased out adoption process. You know, you can wake up one day and hit everybody with data, and create confusion. So I think it's good to have an adoption process. Asking yourself whether you want to start with operational issues, data to improve operations, to improve clinical care and outcomes, or at a strategic level to grow business and so on and so on and so on. So I think that is critical. So then lastly is the people aspect. Yeah, I think it's always good to go and ask the people what data will be useful for you, and what data do you want, and in what format do you want the data, and sometimes if you do that, you get very surprised from the assumptions you had and what the people at the front line are looking for. So I'll just give 3 examples to answer your question. So we, just like Avenue, we have a quality management system, and in this quality management, all the reports, all the near misses and sentinel events and interventions will be put into that system. And so you'll have a lot of data to analyze, to give you trends and to tell you what needs to be done. And I think the people working in pharmacy do the most in terms of putting in data into that system. And so looking at clinical practice, you're trying to standardize clinical practice, and we realized that the majority of doctors had an issue with antihistamine dosing. You know, how to dose, how to communicate, how long to give, whether to give or not to give. And so what we did then was work backwards and develop a decision support tool that helps the clinicians with prescribing antihistamines. And so what that did, other than improving the rationale use of antihistamines, it actually reduced the amount of antihistamines that were being used, because then there were a good percentage of patients who didn't require an antihistamine. So that is just an example of how we use data to do that. And another example relating to quality and safety is patients who go to hospitals will often come back within 72 hours with a similar complaint, and it's usually a good number to look at. If you're at beyond a given percentage, then you're not doing well, and it's always desired to be below a certain percentage. So we realized for certain units the percentage was going up, and before long it was across the hospital, the rate of revisit within 72 hours. And so we had to, because now this is an organization-wide, you know, issue, we had to figure out what is the fastest way to understand what the problem is. And the easiest way to do was to go back to the data. So we went and looked at the pharmacy data, we went and looked at customer complaints, and we realized that the majority of patients who came back had one thing in common: they were on paracetamol. And so the question then was, what is it about paracetamol? You know, and then there was a specific age groups and so on and so on. And then we discovered actually the challenge was that we had introduced a new paracetamol in the system, which had a lot of sugar and which kids didn't like taking. So the revisit rate, and that was probably one of the things we would have thought about last, in terms of trying to, we'll have gotten into the easy thing, get doctors in a room and tell them why revisit rates is high and they need to improve and that kind of thing, which would have had zero impact, yeah? So we had to then go back to the pharmacy and say, guys, the paracetamol we have has a lot of sugar, it's kids are not taking it, fever is not being controlled, and patients are coming back. And then now we had to go into the market to get a sugar-free paracetamol, and we ended up with a company and manufacturer in the UK to do for us sugar-free paracetamol. And the moment we introduced that, the revisit rates went down. So it's just an example of data insight and how you utilize it for decision making. The last example is about resource planning and utilization. So looking at our mobility, we adopted an EHR probably almost 27 years ago. And so we are all of data, and you can easily do mobility analysis. And so we realized that our admissions in the inpatient, when I started working in Gatus, I've been there for long, there are some wards that will come, they were full of asthma, patients wheezing, and there's a seasonality to it, rotavirus, a seasonality to it, and the other thing was pneumonia. So from our morbidity data, we actually realized that those numbers are drastically going down. And so we went back and asked, why are they going down? Then we realized that we had been very aggressive on the vaccination side, what Matolo mentioned. So the rotavirus had come in the picture, and we were very aggressive in doing it. A pneumonia vaccine, very aggressive in doing it, and obviously we're opening more outpatient units, and very aggressive on asthma control. And the measure for us is you reduce the number of ED visits because of asthma, you reduce the number of admissions because of asthma. So that was a very good thing we are doing on the clinical side. But when you talk to the matron and ask them about occupancy rates, he says, look, this thing is hitting me very badly on my occupancy rate. So we tell her, okay, now going back to my issue of resource application, just say don't build more wards. That's, if you have money, talk with the finance guys, just go and open a satellite clinic somewhere and don't deploy that money in opening a new ward, because soon enough there'll be no pneumonias, there'll be no GEs, there'll be no asthmas admitted in the ward. So I think just to give a few examples of how we've tried to, you have to have a repository of data to go back to. It's very useful to do that. But then you need to create a strategy around it and focus. For us, the focus was on quality and safety first, and then operations, and then issues around resource deployment. Thank you.
Thank you very much for the practical examples. And I know the mothers in the house are smiling, and they sure will come and experience that if they haven't yet, utilized the paracetamol without sugar, giving a pharmacy information on to why they need to produce or make paracetamol that's palatable for the children. And the other great examples you've given. In the interest of time, so I'm coming to the last questions before we go to Mentimeter. So I'm coming to you, Dr. Maxwell. Just tell us, from your perspective, has technology had an impact on the communication and collaboration among your healthcare team workflow?
Thank you very much. Of course, the answer is definitely yes. We run a hub and spoke model, whereby we have the main hospital and the 10 other branches spread across. The most important thing in a patient journey is ease of accessing care. And portability of patients is one thing that very many patients suffer from. Today, we can see a patient in Tala and transfer that patient seamlessly to Ruaka, for example, if the husband lives in Ruaka, and continue care from there, without having to make very many phone calls and everything, because everything will give you that thing in the dashboard very easily. So referral of patient, continuity of care, transfer of data, and I think that is one thing the government has done. That is one amazing thing called the digital superhighway that is coming in, and we'd hope this can happen the whole country. That reduces cost of care, it reduces time wasted, and also improves outcome. You can imagine previously a patient comes from Homa Bay, where I grew up, and is referred to Nairobi for care, and they are given a sheet of paper with a report of an ultrasound, of course handwritten. So the doctor wonders, what do I deduce out of this, right? So the doctor will tell the patient, I need to do another ultrasound, unfortunately so. Of course, that is extra money that would not have been used, extra time wasted in making decision, and of course inconvenience to the patient. So that seamless communication between the healthcare service providers has a great impact in outcomes and management of patients. But even if you leave that, now that's on the clinical side, even on management side, every day at midnight I get a telegram message that gives me a high dashboard of how the institution performs, the number of patients, how many have been admitted, how many have been discharged, do we have any mortality, God forbid, how many deliveries did we do? And so that raises the questions, and the next morning when you wake up, you start asking the hard questions, or the good questions for that matter. And so that in itself makes decision making faster, and of course improves, at the end of the day, the essence of all these things we are doing is what is the outcome of the patient management, and is it much more easier? Of course, the other examples were said by Dr. Mohammed, how the nurses would communicate faster, the patient would order for something through the nurse call system. And so, like we say, technology is here to make your life easier. If it doesn't make your life easier, then that's not technology you need, in summary. Thanks.
Thank you very much, Dr. Maxwell. I will take one more question to Dr. Mark Achola. Sorry, Mark, I've given you doctor, it's okay. Just from your discussions earlier, maybe you can share with us any partnerships or collaborations that have been crucial in integrating technology into patient care at your facility or generally. Thank you.
Okay, thank you, Effie. So I think the first thing I'd like to say is that we've got both clinical and non-clinical side of patient care, okay, as much as we're a hospital, and both are very intertwined. Two, if you look at the software environment, we have global players and indigenous players, okay? And again, to me, in my perspective, both are needed, okay? So when you come to collaboration, it works in different ways, okay? So, for example, in our context is that we use global players like Microsoft and Zoho for certain things within our business because they've thought through it, it's mature, it's stable, okay? And it's easy to adapt, and you've got good support, okay? But then you come to organizations like SMART, okay? Because we do a lot of work with SMART. And I'll call SMART in this case because this is the African context, indigenous, okay? So healthcare has a very indigenous approach, yes? Because yes, it's medicine, but it is also the context of where is this medicine practiced, okay? So when I've looked at many, global softwares, you have to do a lot to get them to work in this environment, and especially at the level of hospitals, some of us are running here. So you have to make those decisions very carefully, okay? So when I go to an organization like SMART, my approach is, I want people who are able to customize to my need because they have the ability to, they understand this ecosystem when I'm working with, pairs like Dr. Matolo and what I need to achieve within my environment, So like now we're going a very heavy development phase because we'll be taking up their health management solution, and it's been a very rigorous exercise to get that thing to the level that we want, but it's an issue of we've been able to understand each other, and this is a very good collaboration because they've worked in this environment for years. Of course, personally, I've known the team there for years, but also, we're able to really explain the things we want, and they're able to deliver that within the solution that they have, which becomes very important, okay? We use Microsoft a lot, okay? We're heavy in Valley Hospital. Everybody's on one platform. Clinical and clinical, it doesn't matter. Any staff member can chat me, okay? You don't have to walk into my office because healthcare is a big gossip industry, and everybody sees you walking out of Maxwell's office and saying, what is that nurse going to tell the CEO? Okay, it happens on my phone, okay? If there's an issue, it comes to me real time and say, look, there's a problem, okay? And for me, that's very important because speed of communication is accelerated. Of course, it causes other problems. You understand me? But again, that's management. Okay. So, I think Nyarango talked about discharge. Okay. One of the solutions we have, because the big gripe in hospitals is that insurance companies take long. I think everybody here hears that talk. They tell the patient, we sent the thing, we're calling, no one is responding, all that stuff. So we have a solution where we track when we sent the approval, when Dr. Matola's team approved, and when we actually discharge that patient, to know where is the problem. So I can tell you which insurance companies discharge promptly, and I can tell you where we have a problem, because that has been a big enigma between payers and providers to actually know who is taking responsibility for what. Okay? Because it's a big pain point for a patient when everything has gone well, we're happy, net promoter scores are over the roof. And when you do the assessment, when the patient is leaving, you say, okay, what is your experience? And the discharge process kills the entire thing. But as a hospital, you don't have 100% control over that process. So we decided to take responsibility. and say that, you know what, when Matolo is coming to tell me, Mark, you know your prices, I'll also tell him, you know, Doc, you guys need to speed up. It's a fair conversation, it's a give and take. You know, at the end of the day, so everybody's got work to do. That is, of course, evidence-based. You know, I think that's the most important thing. You know, so, you know, simple examples, but both the thing for me and the take-home for, you know, the colleagues in the room, they are global players and they are indigenous players. And we need them all, because software today it's talking to each other. Yeah. You know, for me who has been in the industry for a very long time, everything was closed at the beginning, and now everything is open. And open works. Take it from me. So it's going well. It's going better.
Thank you very much, Mark. You know, when you say for you who has been in the industry for a long time, and I had alluded earlier that we worked somewhere together, just trying to show people how much we have been here. Very you. But thank you very much for those powerful sentiments on global leaders and also the indigenous leaders in this space. I'll come to you, Dr. Matolo, then I'll come to Dr. Said. Very quickly, I can see Ian looking at me. So I think I have 15 minutes or 20. Then we, 5? Okay, very quickly, Dr. Matolo. In terms of the technology that we've already, Tim? Okay, I think you can hear me? Okay, great. In terms on technology basis and what has worked for you, we would just like to hear some very key lessons from the payer side. Share with us in terms of adopting technology in the healthcare management forums.
Thank you. So I'll speak about some of the solutions that SMART has launched and how the kind of impact it's had. I'll speak about maybe 2 or 3 or 4. So the first one is the e-claim system. Yeah. So when COVID came, and we were told that that thing can be spread even on paper. Yeah, so all the claim forms that were brought that time were being put somewhere to stay in a dark room for some time before anyone even touches them. Yeah, so because of course you know what people are trying to avoid. So at that time is around the same time that we transitioned to an e-claim system, and you know it really made the process quite simple on our side. I know hospitals will probably have a different view on that. Yeah, but you know, you don't have to have a full-time resource just receiving claim forms. You don't have it stacked on people's desks. Yes, you just have everything accessible through the system. So that really helped. I think the other one is the point when Smart Access was launched. Very quickly, but came with very real benefits. And this one, I think for me personally, was, so I have some young people in the house, and whenever you needed to take them to a hospital, by the time you remember which handbag has the cards, it used to take a very long time. Yeah, but these days that's no longer a discussion. So you just walk. If I'm going to one of Dr. Nyarango's branches, I just go there with my phone, I give a visit code, and it just makes that process very seamless. And I think that was really a game changer. Of course, you know, inclusivity becoming part of what needs to be looked at. When we rolled it out, then we realized that there were some of the senior citizens we have who said, no, I don't think I'm insured if I don't have a card. So trying to figure out how to do that, and of course those who don't have smartphones. Then now finally, I think it's around online pre-authorization. So a lot of time when people are saying that there is a delay, you would be shocked when you realize that most of the delay is because of processes that are just not ideal, or using tools that are not fit for purpose. Doing pre-authorization from emails, and especially a group email, takes you much longer than having it just on a dashboard where you quickly go, you review one case, and you approve. So it's actually halved the TATs for approvals on our side, which has a significant benefit for the patient experience. So some of the lessons is really looking at how do you design the process, because it's not automation first, it's really thinking through the process, because sometimes you can automate a process that is inefficient, you'll still get a digital inefficient process. Yeah, so that's something that we always need to look at. I think the other one is also looking at how do you then now make things a bit easier. The reason it also takes time, the discharge TAT, if you send us a 30-page invoice, we will spend time, we will go through all those pages. Yeah, but then now if you have progressive hospitals like Gertrude's where they give you a bill with just one line item, then you can imagine. And our data actually shows, yeah, hospitals that use packages actually have lower discharge TATs. Yeah, because if you have a long one, we will pick something and we will call to ask you why this thing is appearing in the invoice. Yeah, so a lot of it is also designing also how we do things from the hospital side, because it has a real impact on how the insurer reacts. And finally, while we are busy doing our own things, there's a patient left there wondering why these people actually don't seem to care about us. Thank you.
Wow, thank you very much for summarizing very quickly. I'll come over to Dr. Mohammed. I know you already shared how you have empowered your staff and also slightly shared about the patient, but I just want to ask, how else are you empowering the patient to ensure that they are also using the technology so that they can also benefit from that patient-centered care? Because in patient-centered care, definitely we need the payer, who is Dr. Matolo representing us here. We need yourselves, who are the providers, then the patient. So it's a three-legged stool. How do you empower the patient? Thank you.
Yeah, so I hope you can hear. So from a patient perspective, I think the one big technology that we've had to adopt is self-registration, where the patient is able to skip literally the queue at registration and all these other bits. Yeah. So so for example, right now as we speak at the hospital, the cash payers literally just come in. There's a self-service kiosk, enter their details, pay there, and proceed directly into triage nurse or directly to consultation, depending on the service that they've chosen. But also they can also choose their ticket and the doctor they're going to see and all, even if they're not paying to go through that. We are partnering with SMART and similar technology partners to also do this for the insurance patients, right? So that they can easily do that. The idea is to have this just beyond the kiosk and have it as a patient app on their phones, on the patient's phone, so you can literally self-register, book, and do everything beforehand. And I think something interesting Smart mentioned that we're also looking at interesting is when you have multiple facilities, the patient can also be geolocated and told the nearest facility where they can get that service. And even there, where they will be on the queue tracking that Smart spoke about, yeah. So I think I'll give that one example for the sake of time about patient empowerment with technology. Yeah. Thank you.
Thank you very much. A round of applause for the panelists. Thank you. I will quickly take, thank you very much. I'll quickly take a few questions from the Mentimeter. Ian, kindly give me just 5 minutes so we make sure the plenary is also considered. So, and panelists, feel free. Any of you can pick them and answer unless it's specifically allocated to you. So I have one question, and if it probably cuts across to what we've talked about, I'll skip that. How best can technology be used to prevent health insurance fraud? Any of you can take the question. Panelists. I like the way you're all looking at me.
Okay, I'll go for that. Yeah?
Thank you.
Yeah. You know, it's interesting because today's Friday, Wednesday. I got a visit from an insurance company where a client had complained about coming to our hospital, not coming to our hospital actually. So the insurer comes in, you know, unannounced. So we're not ready. They come and say, look, we've got these 2 complaints. We want to investigate the matter. So we sit down, everybody pulls out the information. This insurance company was using Smart, coincidentally, so it's not Harrison or Esther. That's pure coincidence, so it's not like I'm saying it because we're here. and our data aligns. Okay? Because our position was the records, everything shows the patients were here. Benefits are processed, and we all know how SMART works. Okay? So the investigative partner on the other side and us are looking at each other and really asking ourselves what is going on, because processes were followed. Okay? So of course, from a provider perspective, very happy with the outcome. Okay? Because we are like, okay, go and talk to the patient and get more facts, because we really compared detailed information, right from treatment, everything in there. So what am I saying? From a technology standpoint, I think we're really there. But there's a human factor that you can't run away from. Okay? So I just want people to be very clear. Technology is not 100% of the issue. There's also a human factor. But where we are today, I can tell you with my example of Wednesday, which was, totally out of the blue, the approach taken by SMART specifically is working in terms of, preventing, that kind of fraud. And I think it's, we throw the ball back to them to say, if you can give us more, give us more. Because it reduces that deficit of trust that Nyaronga talked about earlier. This went very well.
Dr. Maxwell, you to top up? Okay, great.
Thank you very much. If there's anything that we have done as a country, for example, okay, NHIF, which is SHA today, and I think SMART, there's a biometric, so that literally means you must be there physically. And I think the issue of everyone has a phone, almost the phone penetration in this country is at a highest level across sub-Saharan Africa. When people would get their message notification, that really raised up a lot of fraudulent activities that were taking place. The thing we needed to have done next is to ensure every person confirms their phone number, so that in the event your details are used somewhere, then you're also culpable if you don't whistle blow. But the other place that insurance companies now need to come up from, and someone has said, it's a human issue. And sometimes it's not even an institutional issue. We have instances where, for example, the insurance company has given benefits. For example, they'll tell you, we'll cover the first emergency cesarean section. You understand? And you're laughing because I think it's a very common case. But of course, the patient goes because their cover changed somewhere else and colludes with the doctor in the consultation room. And the cesarean section is not the first, but it's registered as a first. With an integrated digital highway that all insurances have a data sharing, that can actually be reduced completely, so that there's a visibility across board. And it's the interest of all of us that fraud comes to almost zero, because that's when the insurances are financially stable to pay us on time. Because I don't know what percentages of fraud insurances have on average, but that it's substantial money that if could be saved would actually go a long way in actually saving the real patients who need that care. And it becomes a sustainable business, because we're all in business at the end of the day. But that business can only work if all of us are happy. So the insurances, to cover up for their losses sometimes is actually what the people are stealing from them. So just that data sharing across insurance platforms would really help also reduce substantially. Of course, the issue of biometric, phone notifications and stuff like that. These issues of, a patient has been admitted in Kajiado, the same patient walks in Nairobi to a hospital, and they're like, we have one patient in 2 institutions, right? So if that patient had that notification, they would have raised an alarm before they come to this facility in Nairobi.
Very true. Thank you very much for that practical example. I'll take only 2 more, and one goes to Dr. Matolo. Dr. Matolo, do you see this innovation reducing the TAT for payments to providers and quick claim resubmissions where need be? I'm sure you caught it. Do you see this technology or innovation reducing the TAT for payments to providers and quick claim resubmissions where need be?
Yes, so definitely. So the main reasons around delays in claim payment largely revolve around data and how quickly that data reaches the insurer. so that if at a hospital you have billed and for whatever reason the information does not trickle down or doesn't reach the insurer, then that's definitely going to be a delay. I think the issue around, and I know this is a question you've probably been asked by any of the 20-something insurers, please send us the pre-authorization. Yeah, so it came from the insurer, but now all of a sudden we are demanding that you need to send it to us so that we can pay the claim. In such a system, all these records are already available, so that discussion becomes null and void. No one is going to ask you to do that. I think the other bit then, which is going to really make this work, because it's not just about the technology, it's also about the data. The other challenge we have is around data standards and the various nomenclatures that are used, whether it's for diagnosis, whether it's ICD-10, ICD-11, and the various versions that have been there, and then naming of individual services, so that if you don't have standardization, then it becomes a challenge when it comes to the insurer, because you'll find sometimes a claim will be delayed just because it is not clear which specific paracetamol are you referring to, or why is this diagnosis looking different from what has been shared. So there's it will definitely improve and make that whole process a bit more